Good evening. My name is Lauren Dunlap, and I am Executive Director and co-founder of Advocacy and Awareness for Immune Disorders Association, or AAIDA, along with my co-founder, Dr. May O'Connor, who is a practicing immunologist and allergist at Allergy, Asthma, and Immunology Relief in Charlotte, North Carolina. This is Lauren Dunlap and Dr. Maeve O'Connor, Executive Directors for AAIDA, and we are so very pleased to host tonight's webinar. AAIDA's mission is to advocate for patients living with primary immune deficiency, secondary immune deficiency, and autoimmune diseases, and to create awareness and conduct research to find cures for these different groups of diseases. We are so excited to be presenting AAIDA's very first educational webinar, and we are thrilled tonight to be joined by Dr. Teresa Tarrant, who will be speaking on immune deficiency and its association with autoimmunity and malignancy. So primary immune deficiency, or PI for short, are rare genetic defects in the immune system, and PI currently affects about 250,000 people in the U.S. alone, and there are over 400 various types now identified, with CVID being the most prevalent. About 26% of PI patients are affected by an autoimmune disorder at some point in their lifetime, and the risk of malignancy is also greater than the general population for these patients. Questions arise: are specific PIs more susceptible to develop autoimmunity and malignancy than others? And why do only 26% of patients develop an autoimmune disorder while others do not? What is the correlation between PI and malignancy? Dr. Tarrant will answer these questions and more in tonight's webinar.
This is Dr. Maeve O'Connor, and I'm so excited to be able to introduce Dr. Teresa Tarrant. She is a board-certified rheumatologist and allergist immunologist who received her BA at Dartmouth, her medical degree at the University of Florida, and her internal medicine and subspecialty training in allergy, immunology, and rheumatology at Duke University. She is currently Vice Chief of Translational Research for Duke Rheumatology, and her research areas of interest are in new technologies for drug delivery in inflammatory arthritis, Paget's disease, Sjogren's syndrome, and immunodeficiency disorders. Her talk today will be on common variable immunodeficiency, autoimmune, and malignancy risks. Dr. Tarrant, we are so pleased that you could take time in your busy schedule to volunteer to be with us today, and we look forward to the information that you have to share with the audience. Dr. Tarrant, please proceed.
Well, thank you so much for a really lovely introduction from both Maeve and Lauren. It's just a delight to be able to be the flagship talk for this fantastic organization and to hopefully educate more physicians about these rare disorders so that we can improve the care and lives of the patients that we treat. So I just want to begin with some disclosures since this is a CME event. I do serve as a consultant on an advisory board for Thermo Fisher Scientific. That has to do with rheumatoid arthritis testing and platforms for those specific inflammatory arthritides. None of the things that we'll be talking about today have anything to do with that consultancy work, but I did want to disclose that. In terms of our learning goals and objectives, we have four major ones for this evening. The first is to recognize specific primary immunodeficiency disorders and their connection to autoimmune disease, to try to understand better the malignancy risk so that we know which primary immune deficiency disorders are at risk and for what types of malignancies, to identify secondary immune deficiency in the context of perhaps malignancy or anti-neoplastic drugs. So kind of the flip side where someone already has cancer and they're being treated with medications that then lead to immune deficiency. And then ultimately, we're hoping to enable a prompt referral and treatment of these coexisting conditions in our patients. So here's the famous immune system, kind of the overview of the schematic, and we'll be talking about several of these immune cells and how they relate to autoimmune disease and how they relate to primary immune deficiency today. So just to kind of, this little arrow mouse here, we'll be kind of talking about antigen presenting cells and how they talk to T cells, particularly the CD4 helper T cell that then works in concert with B cells, which make antibodies. And a lot of the talk today will be focusing on the humoral immunodeficiencies. These are the ones where our patients do not make good antibody responses. So autoimmunity and primary immune deficiency diseases are pathogenically linked. What we have learned from large registry series, particularly the French National Primary Immunodeficiencies Registry, is that about a quarter of primary immune deficiencies have autoimmunity, and that the genes that are involved in primary immune deficiencies, of the ones that we do know, they actually have overlapping mutations sometimes in some of these genes with rheumatoid arthritis, which is probably one of the better studied autoimmune diseases where we know the genetic risk factors. And not surprisingly, these types of genes are involved in VDJ recombination. That's how a B cell makes a specific antibody through this variable diverse and junction region. Also in central and peripheral tolerance, what that has to do with is T cells being educated in the thymus, for central tolerance, and then for peripheral tolerance, we have, once they are out in the periphery, how they get educated, and then just in how T cells and B cells talk to each other. These are the overall genes that seem to have overlap between autoimmunity and primary immune deficiency. In terms of clinical presentations of primary immune deficiency disorders with autoimmunity, I've listed several here that we will have time to go through some of them, others we will not, but the slides are for your reference in terms of what we'll be focusing on today. So common variable immunodeficiency, or CVID, we're going to spend a good amount of time on, as well as chronic granulomatous disease, because these two primary immune deficiencies have very well characterized autoimmune disorders. One is a humoral immune deficiency, that being CVID, and then CGD is a problem with phagocytic function, or the respiratory bursts of neutrophils. The other primary immune deficiency disorders are actually defects in immune cells, and they don't necessarily make the person more susceptible to infections. So you can see already that primary immune deficiencies don't always have to make you susceptible to infections. Some of these genetic defects actually in and of themselves are kind of autoinflammatory or autoimmune. And so ALPS, or autoimmune lymphoproliferative disorder, this is an apoptosis defect, which means that cells don't die correctly, and so they just keep expanding. These people have a lot of lymphadenopathy and autoimmune disease. And then, believe it or not, complement deficiency, there are some children that are missing certain elements of the complement cascade, and instead of getting infections, these guys actually get lupus that presents in childhood. And then a very newly discovered and described primary immune deficiency disorder, adenosine deaminase 2 deficiency, of which Duke has a very large part in the story of this. I will not have time to talk about today, unfortunately, due to time, but this is worth reading about and understanding how these patients present. Unlike ADA SCID, or severe combined immunodeficiency, adenosine deaminase 2 deficiency presents as autoimmunity. They have vasculitis, particularly polyarteritis nodosa, and they have strokes. So they have a vascular type of phenotype. So one of the things we learn as immunologists is that in those primary immune disorders that have recurrent infections as a part of their phenotype and the way they present, the types of infections people get actually give us an idea into the nature of the immunologic defect. So basically, T cell deficiencies, these are basically the severe combined immunodeficiency disorders. And what we've learned is that medicines we've used for autoimmunity that target T cells end up having the same types of infections as primary immune deficiency disorders with these diseases. So they end up having problems with fungus infection, viruses, and PCP, or pneumocystis infections. And similarly, the medications that are available for prescribing for autoimmune disease, that being abatacept, which targets co-stimulation, CD28 and B7 interactions between the T cell and B cell. Prednisone is definitely an immune suppressant of T cells. cyclophosphamide, and the JAK-inhibitors, which are new medications basically involved in JAK-STAT signaling of T-cell receptor cytokines. These all lead to infection problems, sometimes with fungus, viruses, and pneumocystis, like we see in severe combined immunodeficiency. Whereas our B-cell deficiencies, this would be our CVID and humoral immunodeficiency disorders, these patients have more problems with bacterial infections, particularly of the cyanopulmonary tree with pneumococcus, influenza, and enteroviruses. And interestingly, our medications to treat autoimmunity, rituximab and belimumab, which target B cells, you can see in people who get those medicines repeatedly that they can have those types of pathogens as a part of their complications if they have problems with those medicines. And then TNF alpha inhibition in the autoimmune world, we ended up figuring out that even though TNF neutralization was fantastic to treat a lot of autoimmune diseases, that's an important cytokine to help fight off infections too, because there were some people who ended up having mycobacterial infections, histoplasmosis, listeria, and Legionnaire's disease. So sometimes the immunologist, what may be something that you end up seeing more in your practice than in primary immune deficiency disorders is the flip of that, which is people we've made secondarily immune deficient with these types of medicines that are now widely being prescribed. So we've learned from primary immune deficiency, and we can extrapolate maybe to a broader population. And similarly, it's helped us understand PIDD as well. So I know it's always kind of nice to think through these immunology problems and patient case scenarios with a case. So I'm going to kind of talk with you a little bit about cases that we've seen in the clinic and kind of how they taught us about autoimmunity or about malignancy risk. So this is a 30-year-old who was previously healthy, who presented first to the rheumatologist with joint pain. And she had no family history of autoimmune disease or immune deficiency, but she had 2 autoimmune diseases already as a 30-year-old. She was hypothyroid and she had autoimmune vitiligo, which was kind of unusual. And so the rheumatologist is seeing her for joint pain, and they do some radiographs and they do a clinical exam, and they see what looks like what we call seronegative rheumatoid arthritis, meaning that the antibodies are negative, but the clinical disease with the exam and the x-rays looks like it's an inflammatory arthritis. And etanercept, which is a TNF inhibitor medication, was added ultimately after methotrexate as step-up therapy to treat this inflammatory arthritis. And after 2 months, the patient develops pneumonia, which is not something she had had before. But she did say when we started talking to her about, have you ever had problems with infections in the past? She's like, yeah, I've just been plagued by sinus infections and feeling sick all the time, ever since I was young that I can remember. And so the medicine is stopped and she improves. And they pick a different medication that's FDA approved for rheumatoid arthritis, and that's rituximab. This targets CD20, which is an antigen on B cells only, and it removes B cells from the circulation. And so in that process, someone ordered some screening immunoglobulins because rituximab is known to have vaccination responses kind of wane over time. So some people check immunoglobulins before starting the medication. Some people check it if someone's saying they're having recurrent infections, and they end up actually having very low antibodies, undetectable IgA and less than normal IgG, and the IgM is in normal range. So does this patient have primary immune deficiency? Have they developed a secondary immune deficiency from their drugs? And how does autoimmunity fit with respect to thinking about this patient and what you think they have and what you should be treating moving forward? So as you can see from this list, the differential diagnosis is really quite large. So we have medications that have been known to cause secondary immunodeficiency, and this is a short list, rituximab being on there, as you can see. HIV has actually, which is a secondary immunodeficiency, that has been shown to be associated with a higher incidence of Crohn's disease, psoriasis, and sometimes the seronegative axial spondyloarthropathies. Cancer, so someone having cancer, like Good syndrome, can have immunodeficiency and autoimmunity. CVID, which we've talked about, that being that you have low antibodies and you have recurrent infections, and then a subset of those patients have autoimmunity. Could this just be IgA deficiency? Because those patients who are complete absolute IgA deficient have a higher incidence of allergy and associated autoimmune disease than their age-matched cohorts. And sickle cell disease is another thing where we see kind of an unusual incidence of autoimmunity, and then they are immunodeficient because their spleen does not work normally. Basically, what happens with sickling over many, many years, their spleen no longer makes appropriate or as good of antibody responses to encapsulated organisms like pneumococcus. So that's why we see in our sickle cell patients that they're being vaccinated to pneumococcal as well as Haemophilus influenza by their hematologist. So it's a really big list when you're thinking about this patient, and there becomes this kind of chicken and an egg where you say, well, was the autoimmunity because they have PIDD, or did they have autoimmunity and get a secondary immune deficiency because of the drugs they were on? So as you can see, it's not always straightforward. So let's kind of take a deeper dive into common variable immunodeficiency. It's a funky name, and I remember when I was in fellowship, I wondered, how do we come up with this name? And the reason is that it is perceived to be a relatively common immunodeficiency compared to all the others. So if you think about the incidence of immune deficiency, as you heard from the intro, it's actually quite low, but CVID has a variable incidence as well as variable levels of the immunoglobulins. So no one CVID patient looks just like another, and their clinical course can be very variable as well. So that's kind of how the name evolved. And its prevalence is widely estimated, 1 in 25,000 to 1 in 200,000. And what that means to me is we still don't recognize this disease very well. And some centers and some areas recognize it better than others. And so they maybe have a higher incidence, and then others, it's maybe being underdiagnosed. And if you talk to a lot of patients with CVID, it's very rare that one of them will tell you, as soon as I started getting sick, they knew exactly what was going on. I mean, they kind of give a story of it was several years of kind of going to different specialists and trying to figure out what was going on before the diagnosis is made. In general, most patients will present with bacterial infections, although we do see a minority who present with autoimmunity, which could be this case scenario we're discussing. Autoimmune disease is present in about 1 in 5 or 1 in 4 CVID patients. It is associated with malignancy, and we'll talk a little bit more about that. Although it's not a common complication, it is a higher incidence than the general population. And in general, we see it onset in the teens or in kind of young adulthood. And we don't necessarily see more men or women. We see an equal incidence of that, depending. That doesn't seem to depend on your gender. In terms of how doctors make the diagnosis, we like to see that the IgG is more than 2 standard deviations below normal. So it's got to be really low. It can't just be kind of like right under the normal range. And then we like to see another immunoglobulin class that's at the 5th percentile or 2 standard deviations much lower than what is considered normal. So you really need 2 to be quite low for that to be a diagnosis of CVID. And it's not just the value that's important, it's also, are people getting sick, or do they have impaired vaccination responses? So most patients have a history of infection, and they are typically sinusitis, otitis, pneumonias. But every once in a while, we do find people who tell us they're not sick, and so we check their vaccination titers, because if they have received vaccinations on a normal schedule, they should have protective antibodies. And if they don't, then that kind of becomes concerning. And like I said, in rare cases, autoimmunity presents prior to any history of infection. So just to kind of really hit home this point of quality, not quantity, it's not just the total levels, it's also Are the vaccination responses normal, or are they boosting if you give someone a booster vaccination appropriately? And the way we do this is we give people the vaccines, and we like to see that they either move into protective range or they have a 2 to 4-fold rise from baseline after we immunize them with the vaccines. So in terms of the genetics of CVID, there certainly is some heritability in some families. So some families have a real strong signature of autoimmune disease and or immunodeficiency, but really most cases are sporadic, meaning there's not anybody in the family that has immune deficiency. However, there are some extended families that have both IgA deficiency and CVID within extended relatives. About 15% of patients with CVID do have someone who either has IgA deficiency or an immune deficiency that's humoral. And we also see that some people who have IgA deficiency, who maybe kind of have borderline other immunoglobulins, kind of evolve into CVID over time. So we certainly see folks like that. We don't know how many people are out there because we're not just screening immunoglobulins all the time. That would be pretty expensive and kind of like a needle in a haystack. But we do know that exists. And the major histocompatibility haplotype, this is the MHC. These are kind of, again, things on antigen-presenting cells, surface receptors on antigen-presenting cells that recognize proteins and foreign proteins. And we do know that some of those show commonality between CVID and IgA deficiency. So there are some genes that, we see a trend towards increased susceptibility. But in CVID, it's different than some of our other primary immune disorders where we know there is one gene and that one gene is abnormal and we know the mutations. CVID is probably not one single gene. It's probably a cluster of genes that have to go kind of wrong in order to develop CVID. And honestly, that's really the same case for autoimmunity, because in most autoimmune diseases, we don't have a single gene that is defective. It's probably several different genes that are interacting, as well as perhaps an environmental influence. So it's not quite as straightforward figuring out the genetics of these complex immune disorders. I want to spend a little time talking about selective IgA deficiency because that's actually quite common, particularly in the Caucasian population. So only, 1 in 500 folks are walking around who are probably IgA deficient, but the spectrum of how you feel is very broad. So most people are asymptomatic. They actually have no clinical symptoms of recurrent infections. They have no stomach problems, and they would be found accidentally. We actually had an example in my medical school class where in our immunology rotation, we were all tested for our IgA levels as we were kind of learning how those lab tests work. And the instructor joked that he found someone who was IgA deficient in every single medical school class. And sure enough, we had someone who had no idea that they were IgA deficient, and they were found on the assay. So this is something where, it has associations with infection, it has associations with autoimmunity, but it's so common and the spectrum is so broad, we don't hang a lot of it on just that. But just know that selective IgA deficiency is probably within the continuum. In terms of what types of autoimmune diseases might be more associated with IgA deficiency, immune thrombocytopenia, lupus, rheumatoid arthritis, and celiac disease are the ones that we kind of see more of. And then we're going to talk a little bit about TACI mutations, which have been described. This is another genetic risk factor that overlaps with CVID and particularly associates with the autoimmune subset of people who have immune deficiency and autoimmune disease. So like I said, a few monogenetic cases have been pulled out of the CVID cohorts, but they're very rare. So there's only one patient described with a mutation in the BAFF receptor gene, and this is a gene that's involved in B cell survival and growth on B cells. So it makes sense that if you got a defect there, your B cells aren't working right, and you have maybe CVID, but only one patient's been described. And then other patients with B cell markers, that being CD19, CD21, CD20, and CD81, again, very, very rare cases where these people are deficient in those genes and therefore their B cells aren't working right. Autosomal recessive cases have been described in ICOS, protein kinase C, and LRBA. If you're doing literature searches, it seems like LRBA gene mutations can be associated with practically everything. So these types of mutations are out there, but I don't necessarily recommend screening for them in your CVID patients. It's only if you have someone that's really kind of severe and fits in with some of these more rare disorders, which are usually, to be honest, presenting more in childhood than in adulthood, that you could consider it. But in most cases, and then they also might have a family history, but in most cases, you're not necessarily going to be doing genetic testing for these. And many of them are not commercially available. You would have to work with a research lab to get that done. NF-kappa B is a protein that's really important in inflammatory signaling. And both NF-kappa B1 and 2 mutations have been described in CVID with autoimmunity. And then as we talked about TACI, this is in the TNF receptor family. It is more associated with autoimmunity, but it's complicated in that sometimes people with 2 copies of the bad gene actually have no disease, and then if 1 copy, they have disease. So it's not straightforward, but about 10 to 20% of CVID cases with autoimmunity have a TACI mutation. So it's kind of taught us a little bit about how that protein might be important in autoimmune phenotypes, but again, it doesn't change how we take care of patients. We still are taking care of them the same way. So we're still probably learning more about the TACI story for right now. So in terms of autoimmunity, we've said about 1 1/4 patients. And in terms of what are the diseases, what autoimmune diseases do they present with? They don't present with all of them, to be honest. They're usually most commonly autoimmune blood disorders, so autoimmune thrombocytopenia, autoimmune hemolytic anemia. That's pretty much cited in most cohorts as being the most common. Since I am a rheumatologist, as you can imagine, there's probably some referral bias there. So I have a larger group of folks who have inflammatory arthritis and who have keratoconjunctivitis sicca, which is a Sjogren's like dry mouth, dry eyes phenotype. In terms of vitiligo, we kind of see that as well as autoimmune thyroiditis sprinkled throughout all of them. Alopecia areata, again, have patients with that. But in general, we see, a lot of them. What you don't see, I guess the ones that I would like kind of to highlight that we don't see as much are the demyelinating disorders. So we don't see more Guillain-Barré, we don't see more MS. I think I've had 1 patient with optic neuritis, but again, that is very uncommon. So for some reason, the genes don't overlap with every single autoimmune disease, which is probably worth noting and thinking about. So this patient that we were kind of talking about in our case presentation had autoimmune thyroiditis, vitiligo, and inflammatory arthritis. And one of the things I kind of notice about the CVID patients with autoimmunity that I take care of is that very commonly, when they have autoimmune disease, they have a lot more than 1. So that's another kind of tip off sometimes if you're wondering, is it the primary immunodeficiency kind of driving this with the patient we were discussing? Because she had 3 autoimmune diseases at that point, and that's not the typical rheumatoid arthritis patient. So something to kind of think about there is a way to think about risk factors for primary immunodeficiency. So rituximab, as I kind of touched on, it's anti-CD20 ablative therapy, and it's not only FDA approved for the autoimmune disorder of rheumatoid arthritis, it's actually now a game changer for ANCA vasculitis. And it has been a long time approved for immune thrombocytopenia and autoimmune hemolytic anemia. And the reason why it's important for us as immunologists to kind of understand this medicine and how it works and how secondary immune deficiency may be connected with it is because it's being used now for a lot of autoimmune diseases, and a lot of patients are being exposed. So there actually are case reports of people who usually had cancer, but not always. We certainly have rheumatoid arthritis patients as well, who they have permanent B-cell loss, and then they develop a subsequent immunoglobulin deficiency after exposure to rituximab. We don't know why those patients in particular had that adverse outcome. Most patients repopulate their B cells within a year after getting rituximab if you were not to give it again. But for some reason, we have some patients who do not, and they actually develop secondary immune deficiency. And then, as I kind of alluded to before, because this does affect the B cells in terms of being around in their circulation, if you get rituximab over and over and over again for chronic autoimmune disease, we do see that some people have less robust vaccination titers over time. So if you're measuring vaccination titers in an immunodeficiency workup and someone has been receiving rituximab, it's hard to know if the drug didn't maybe make those levels low. So you have to kind of keep that in mind when you're thinking about how you interpret the data for patients who've been on rituximab. So here's the big conundrum with this patient is which came first? Did they have a seronegative inflammatory arthritis and they had CVID, but just didn't know it because they hadn't had infections, and the autoimmunity was presenting first clinically, and that's why you ended up kind of seeing them. And basically when they got put on immunosuppressive drugs, it made them then have infections. So is that what's going on in this patient? Or is it that they have a primary immune deficiency? So kind of compelling in terms of kind of how you think about it. But in terms of how I thought about it, I, at the end of the day, felt like the patient had not been exposed to enough rituximab to have created the secondary immunodeficiency. And having those 3 autoimmune diseases and low immunoglobulins, I basically thought it was that they probably had had CVID and that their infections came out with the immune deficiency. So as rheumatologists, we're kind of trying to educate our group about, if people start having a lot of infections on immunosuppressive drugs, think about how once that drug is discontinued, if they're still having infections, maybe you have just unmasked a primary immune deficiency that nobody kind of knew about before. So it's something to think about there. And then what we did was we did follow that patient out, and their B cells repopulated. So they basically had normal levels of B cells after the rituximab was stopped. And so we definitely thought then that that was not a drug effect, because rituximab, they have permanent loss of their B cells. And most CVID patients have normal or low normal levels of B cells. So that was another way that we were able to distinguish that. So a new case scenario to kind of think about primary immune deficiency. This is a 22-year-old young man who has chronic diarrhea. And they had been seen by the gastroenterologist, and they had recurrent infections with C. difficile infection that had been attributed to, well, they were on a lot of antibiotics for recurrent sinus infections. And then he basically went on 2 courses of treatment and still had persistent diarrhea symptoms. So you kind of start talking to him about diet and could this be celiac, and you order a tissue transglutaminase antibody as well as a total IgA level before you send him to GI for consultation and for colonoscopy. And the GI guys are actually really pretty good about this, where they know that the tissue transglutaminase antibody is an IgA antibody test. And as you remember, 1 in 500 people are absolute IgA deficient and asymptomatic. So that test is not valid if you order it in someone who's IgA deficient. You just can't interpret it. So they're running both to make sure that they've not identified someone where the test can't be interpreted and you have a false negative. In the case of those individuals, they will just need to go to colonoscopy and biopsy to determine if they have celiac disease. So the tissue transglutaminase IgA antibody is negative, but they're also IgA deficient. So therefore the test is not valid. And you're kind of suspicious with the recurrent diarrhea. So you order quantitative immunoglobulins and the IgG is quite low. The IgA is absent, but you knew that already. And the IgM is also low. And the gastroenterologist finds an abnormal colonoscopy. So in terms of CVID, so this patient probably has CVID. So let's talk about gastrointestinal symptoms, because I think these are probably, again, something that's very under-recognized. And the autoimmune spectrum, as well as the infectious spectrum, is quite large for these patients. So they tend to have sometimes problems with recurrent giardia. So if a patient with CVID or immune deficiency, that's humoral immune deficiency, is having recurrent diarrhea, you want to screen for infections. So this being giardia. I have a couple of patients who really have had problems with chronic norovirus. I've also seen CMV and the enteroviruses. So particularly if it's someone who's not had diarrhea before, you would want to run those tests and just make sure this isn't an infection that you need to treat. However, there's also autoimmune disease. They can have gastric atrophy and achlorhydria and vitamin B12 absorption problems. They can have a sprue-like syndrome that looks just like celiac sprue with lots of weight loss, diarrhea, vitamin deficiency. Their biopsy looks just like sprue, although they have slightly different inflammation patterns that the pathologists are usually pretty good at dissecting out sprue versus not sprue. But we see this actually quite a bit in CVID patients. And then they have a colitis, which is more like what looks like an inflammatory bowel, Crohn's disease colitis. They can have nodular follicular hyperplasia, and that's actually that picture that I showed you with those kind of little lumpy, bumpy appearances in the intestine. And they're at a higher risk for lymphoma of the gut, as well as a condition called nodular regenerative hyperplasia of the liver, which I'm going to show you a picture of. And this is typically where I have seen it. It has been in CVID patients who have known inflammatory bowel disease, and they've been on immune suppression a long time. And we're not really sure why some of these patients develop this, but there's a real linkage between having inflammatory bowel autoimmune disease and then CVID with these patients. So these are kind of the big ones that we see that are autoimmune that I'm kind of highlighting here, as opposed to being cancer or infection driven. So here's this picture again of the nodular lymphoid hyperplasia. What's important to recognize about this condition is it really is seen almost exclusively in CVID. So sometimes gastroenterologists might refer to you just with this view of colonoscopy and say, hey, what's going on here? And you certainly want to screen immunoglobulins in anybody who has a colonoscopy like this. The good news is it's actually not linked to an increased risk of cancer, which is fantastic. So having this type of almost overproduction, overactive lymph node cells within the gut does not increase your risk of cancer. One way of thinking about this is that perhaps because in CVID, you know, the response to infection is not the same. It's like the immune system in your gut is trying really, really hard to work overtime. And that may be what's going on there. And then to our right, we see the nodular regenerative hyperplasia of the liver. It's kind of, again, on low power, you see these kind of what looks like nodules. It has a strong correlation with CVID patients who also have inflammatory bowel disease. And it can be a very difficult complication to manage, resulting in cirrhosis and liver failure, unfortunately, and does not seem to respond to immune suppression. So in this case that we've been discussing, you first kind of simple things, you rule out infections like Giardia and H. pylori, and you end up seeing that the histopath comes back from the gastroenterologist and it shows collagenous colitis. So you start treating with immune suppression, which oftentimes is helpful for patients who are having diarrhea and autoimmune disease of the gut from CVID. And you decide to check the immunoglobulins again after the diarrhea is better. And the reason why is that diarrhea in and of itself can sometimes falsely lead to low immunoglobulin levels. And particularly if someone tells you they're stooling 20 times a day, which can be the case for some of these patients. So you do ultimately want to maybe recheck those immunoglobulins after you've got the inflammation of the gut that are treated with prednisone or another immune suppressive drug to make sure that it's not a false low value before you kind of make that diagnosis of CVID. And of course, you would also do the same thing where you'd be talking to the patient about infections and you would be doing a vaccination assessment of them to determine if they have normal levels, and if not, do they respond to boost? So in this patient then that did have the diarrhea that was now fixed, their total immunoglobulins are still more than 2 standard deviations below normal. Their vaccination titers do not boost. So we do kind of believe at the end that this patient is a likely CVID patient that has been discovered. Another case scenario. So we're still on CVID, believe it or not. It shows you how diverse this disease really can be. So this is a 40-year-old individual who was diagnosed and carries a diagnosis of sarcoid, sarcoidosis involving the lung as well as the liver. And this has been biopsy proving. And they also had imaging on CT scan done 5 years ago. And so people were like, yeah, this is sarcoid. They'd previously been on numerous immunosuppressants to kind of treat the sarcoidosis, including steroids, methotrexate, and azathioprine. But on these immunosuppressant medications, they kept having to be stopped because the patient kept having infections, limiting their treatment. So again, you're thinking, you know, having trouble with immune suppression, overly problematic with infections, you know, is this really sarcoid or is this something else? So you're ordering quantitative immunoglobulins because there is a sarcoid phenotype within CVID. So there's this autoimmune phenotype, and sure enough, they're super low. So in this area of the country, we see a much higher incidence of sarcoidosis than we do in other parts of the country. So sarcoidosis is not uncommon. However, people are having problems with recurrent infections may actually have been kind of misdiagnosed as just having sarcoid when actually they have CVID with granulomatous disease. So basically immunodeficiency with autoimmunity looking like sarcoid. So one of the things you always kind of ask is, you know, how do you know that it's primary sarcoid versus the granulomatous interstitial lung disease or GILD associated with CVID? One thing is the infections. So talk to the patients about, are you having infections on immune suppression, off immune suppression? And a lot of times you'll find sarcoid patients do not have recurrent infections, but CVID patients do. Sarcoid patients have normal levels of immunoglobulins, and sometimes they're actually even high because they have a hyperactive, overactive immune response. So that's a way you can kind of distinguish. Vaccination responses, sarcoidosis patients should make fine responses to vaccinations and have normal vaccination levels, whereas CVID would not. And the other thing that's kind of note, but not a hard and fast rule, is that although we are relatively endemic for sarcoidosis, we do see a definite ethnic bias in this country where African Americans are more disproportionately affected, whereas in the Scandinavian countries, it is more a Caucasian phenotype. Whereas CVID, we see the shift the other way, in that Caucasians tend to have a higher incidence of CVID as compared to perhaps sarcoidosis. So sometimes, although it's not hard and fast, you know, you can use race as a way to kind of think about these patients and maybe help a little bit. The treatment is very different. So in sarcoidosis, methotrexate and TNF neutralization really is kind of standard of care to help these patients with inflammation that is persistent, because sometimes in sarcoidosis, the inflammation just goes away on its own. And many of us know pulmonologists who will just watch and wait, and the increased lymph nodes and interstitial disease might go away on its own. But oftentimes it's steroids, methotrexate, and TNF in very refractory cases. Whereas in CVID, TNF neutralization tends to make people sicker. Basically the experience from the Rudis group is that in GILD in particular, the azathioprine rituximab combination has been a game changer for helping those patients with this particular autoimmune disease. And we know that azathioprine plus rituximab in primary sarcoidosis patients does not work. So understanding which category your patient goes into really does actually have treatment management implications that are important to know. So let's talk a little bit. We've talked about kind of the autoimmune disease signature, the big GI disease signature that has a lot of autoimmunity, and let's talk now about pulmonary symptoms, because that's a huge part of CVID, both autoimmune and not. So typically the big thing you hear about is pneumonia, pneumonia, pneumonia. And that's why we put patients on immune globulin replacement products, is because it's to protect them from pneumonias. And if we protect them from pneumonias, they're less likely to get bronchiectasis and pulmonary fibrosis. So that's really important. But a subset of these guys actually have autoimmune disease, and that's the sarcoid granulomatous pulmonary involvement and then lymphocytic interstitial pneumonia, both of which kind of look similar to sarcoidosis. And these are the patients with that type of autoimmune inflammation that basically really respond to azathioprine and rituximab. So treating them, I think, is really important. I have several patients that have undergone this protocol, and again, it's been a complete game changer for them. If you see the CT scan here again from the Rudis paper, That's a really bad looking lung CT with a lot of ground glass and inflammation that completely normalizes on this therapy. And I can basically agree that the Duke experience is the same. So, so this is kind of a really nice, I think, contribution to the field that group has provided for our patients. In general, these patients tolerate this medication protocol very well without adverse events. And like I said, they have improvement not only in the imaging, but also in their lung function. So we've talked about all these autoimmune diseases and CVID. It's a balancing act, right? Because they have an immune deficiency, but they have an overactive component of their immune system and need to be on immune suppression. So there's no hard and fast guidelines about what types of immunosuppressant medications to use, but this is a list that I kind of move through with my patients with patients who have autoimmune disease as well as CVID, with kind of the first one being the least immunosuppressive and kind of moving down into the ones that are more immunosuppressive. In general, many of us who care for these patients with both conditions have found that TNF neutralization may lead to unacceptable infection rates. So that's why I do not have these medications on my list for CVID. I've not necessarily found them to be helpful in that, you know, they might control the autoimmune inflammation, but we tend to make the infections worse. So I proceed with caution when I need to use those. And then JAK-NIBs, which are one of the newest medications that have been approved for rheumatoid arthritis and alopecia areata. You know, I don't really have much experience using them off-label in CVID with their autoimmune diseases. So I think the thing you would worry about would be reactivation with herpes viruses, because that's what's been seen in immunocompetent patients with RA, is that there is more reactivation of CMV and varicella zoster. So I think you need to proceed with caution in our immune deficient patients. And like I said, I usually have found these other medications to be more helpful and not increasing their infection risk. And then finally, even less experience with anti-IL-17 and anti-P40, which is IL-12 and 23 neutralization. These are both medications being used in psoriasis, largely, as well as inflammatory bowel disease. I do have some patients on the anti-P40 inhibitor, Stelara, for IBD, and we've not seen an increase in infections. So that's promising. CVID treatment, I think I'll kind of move quickly through this for the nature of time, because I think a lot of people know how to treat CVID. The general guidelines are pretty well published that you're in a range of 300 to 500 milligrams per kilogram every 3 to 4 weeks if you're doing IVIG, but most people have moved over to subcutaneous. Again, similar dosing, except you're doing it sub-Q and the patient gets to administer it at home, and it's weekly, so it's divided into weekly doses most commonly, although patients can have flexibility in terms of how they might change that dosing. So some patients do every 2 weeks, and some patients might do more smaller amounts, but more injections during the week. And that's nice that they have the flexibility to be able to do that. Basically, you want to always try to detect and treat pulmonary infections with antibiotics as soon as you can. We avoid live vaccines. And treatment with immune suppression is frequently needed for autoimmune manifestations. So the other thing I try to kind of counsel physicians about is you don't hold the immune suppression for the autoimmune disease, because it can really help them. And so even though it might seem a little scary, you know, if they're on IgG replacement, their risk of recurrent infections will be less. So if they're not on IgG replacement, that's another story. But if they're on IgG replacement, you know, you need to treat the unchecked inflammation and help them from that standpoint as well. In terms of CVID mimicking sarcoidosis, it also can kind of mimic lymphoproliferative disorders that look like lymphoma. So we see granulomatous disease, but we also see splenomegaly, and there is an increased incidence of blood cancers. So we'll talk a little bit about that. One way to think about the increased malignancy incidence that I like to kind of compare it to is, you know, RA and Sjogren's and inflammatory bowel disease. We know in those larger cohorts kind of the increase in malignancy for them. So basically there's a 4-fold increase in lymphomas in Sjogren's syndrome, which is the autoimmune disease of your lacrimal glands and your salivary glands. So they have a lot of dryness because the exocrine gland function is under attack. Well, you have a 5-fold increase of lymphoma, particularly non-Hodgkin's lymphoma and CVID. So that kind of gives you an idea of comparable risk. In CVID, you have a 10 to 50-fold increase in gastric carcinoma, as well as the mucosal associated lymphoid tissue lymphoma or MALT lymphoma. So you see more increased malignancy in the gut. But you also see an increased incidence of cancer in inflammatory bowel disease, as well as an increased incidence of lymphoreticular or lymphoma malignancy in RA. So, you know, the question that sometimes comes up is like, well, what if I'm a CVID patient and I have autoimmunity and I have one of these autoimmune diseases also? Does that mean that my risk is doubled? And probably not, because what we've learned is that there are 2 distinct phenotypes of CVID. There's the ones that have just infections and never have autoimmune disease, and their overall favorable prognosis is quite good once you get them on IgG replacement. I mean, they really just can kind of cruise and have not a lot of problems. And their life expectancy is actually very similar to people who don't have CVID once they're on good medicine. The ones with the autoimmune disease or the lymphoproliferation, these are the ones like regular, quote unquote, regular patients who don't have immune deficiency with autoimmune disease. They're the ones with increased risk. So really, it's not a double whammy if you have CVID. It's probably, honestly, just the autoimmune disease itself that is really the increased risk. So not as much having CVID, but having the autoimmune phenotype is maybe what's increasing the malignancy risk, as we see in patients with autoimmune disease who don't have CVID. So we'll touch on, we've spent a lot of time on CVID, and it is basically 5 minutes to go. So I'm going to kind of chat about some rare syndromes now that are seen a lot less commonly. And then basically we'll do it for a couple of minutes, and I do want to spend some time for questions, because I know people might have questions. So we'll go through good syndrome, and then I'm going to let Lauren take some questions so that we don't leave you guys hanging. And like I said, there's so much to talk about sometimes that we can't get through it all, but hopefully I've given you some good food for thought. Good syndrome I want you not to forget about, because when we think about thymomas, we think about myasthenia gravis, which is an autoimmune disease, but some of these patients actually get secondary.
Couple of technicalities working on.
While Lauren is working on the technological aspects, this is Dr. Maeve O'Connor, and I just want to say that tonight's webinar supports the purpose of AAIDA. We're here to educate patients and providers alike, to advocate for patients living with immune disorders, create awareness about immune disorders, and to make strides in research to find cures and novel treatment options for these diseases. There are so many ways that each and every one of you could get involved and become a part of and support AAIDA. You can become a volunteer and donate your time. You can donate plasma at a local plasma center. We know there are multiple shortages. Or you can make a tax-deductible donation today. We want to let you know that we're going to have more webinars such as tonight. And I'm going to let Lauren see if her technological issues are solved. Lauren?
Lauren, I have got audio, I think, again. Can you hear me?
Yes, we can hear you now, Dr. Tarrant.
Oh, good. Sorry about that.
You're back.
And all of a sudden died. So if we have time for questions, I'm happy to take them.
Okay, we have a couple of questions, and also the audience, feel free to type into the box, and I can see those questions as they come through, and we'll ask her. So Dr. Tarrant, can you explain when When should a new parent be concerned about a newborn with ongoing infections?
So I think that in childhood and in infancy, you kind of have different things going on with respect to recurrent infections. What I counsel my CVID patients about is, there's a lot of times a concern about when I have kids, what's the genetic risk for autoimmunity? What's the genetic risk for CVID passing on to my kids? And what I try to counsel people about is to say, at the end of the day, it's probably a 10% risk that they're IgA deficient and a 2% risk that they get CVID. So it's really not common. And usually recurrent infections are allergies and kind of common things being common. Kids get sick. So I think working with your pediatrician and basically kind of seeing if the infections are within the range of normal for normal children is the most important thing. It's not normal for little kids to get pneumonias. So I think serious infections is when people kind of, start thinking outside the box. But the kids are going to get lots of infections, viruses, sinusitis, otitis media. So I try to kind of counsel people to, take a breath, and it is much more likely than not that your kid is normal.
Thank you. When should an immunologist ask for a rheumatology consult or a peer-to-peer?
So I think one of the things that is important for everybody to realize, and a lot of people forget, and so including rheumatologists in your community, is the immunologist is really helpful when they tell the rheumatologist, who maybe isn't as familiar with the humoral immunodeficiencies, that all antibody tests are not valid. Because the rheumatologist loves to order autoantibodies, right? They're going to order the rheumatoid factor. They're going to order the ANCA test. All of these will be negative in someone who can't make antibodies. And if they're on IgG replacement, whatever you're measuring has to do with the 1,000 people who were pooled to make that IgG product for you. So they really need to do a clinical history and exam in these patients. That's going to end up being the most diagnostic for them. And so when your CVID patient tells you they have joint pain and swelling, when they have dry mouth, dry eyes, when they obviously have vitiligo, which is pretty easy to see, that's maybe when you might want to rope in the rheumatologist. But we can be very helpful to them in educating them about the appropriate or inappropriate use of antibody testing in these patients, because it sometimes is spending a lot of money that wasn't of any clinical diagnostic value.
Thank you. We're going to do one more question for the sake of time. Can you explain, Dr. Tarrant, what is the difference for a private practice immunologist who does research versus an academic immunologist?
So I think that, it's hard for me to define a private practice immunologist's work because I am not one. So I think that one way to think about it is talking with your immunologist. So most private practice clinicians are clinicians, and they're seeing patients every day. And that is their main job. And if they're doing research, most of them are doing clinically related research and maybe industry sponsored research. An academic immunologist, allergist immunologist, is usually somebody who also is seeing patients, but they may be doing more basic science research at the bench. They may be doing more epidemiology. They may have a more limited scope of practice that they focus on deeper. So, in my practice, I select for CVID patients. So I have a large group of people that I choose to see for CVID, probably over other diseases, because I'm very interested in that. And that's kind of how that is set up in an academic center, because you might be interested in doing types of research that industry is less interested in doing. So you're not necessarily just prescribing a new drug, you are trying to study how the disease actually works.
Thank you, Dr. Tarrant. I know we're short on time, so we're going to quickly wrap up. Did you need to add anything else?
I think the only thing I would end with is, we had so much to go through and we just couldn't get through it all, but I was going to go to the kind of wrap up slide here just to kind of end with, because many of these other disorders are things that are much more rare than CVID. So kind of the take-home points for the webinar are the overlapping immune mechanism between autoimmunity and primary immune deficiency, how many of the autoimmune diseases, if they present first, might have more subtle infection history. So you need to ask in patients who might have infections and kind of dig a little deeper. These new biologics, we have so many now that are on the market, and they actually may exacerbate infection in unrecognized primary immune deficiency disorders. So rather than just making a quick knee-jerk switch, it's maybe worth understanding what those infections are and doing an immunodeficiency workup in some patients to see if maybe, again, you have an unrecognized primary immune deficiency. And the infection history and understanding the pattern of the immune defects is probably going to help us diagnose and treat people a lot better if we spend the time to kind of understand those relationships.
Thank you, Dr. Tarrant, and thank you for your time and volunteering for this webinar this evening. We truly appreciate it. Thank you to the audience members for listening this evening. We hope you will join us for our next educational webinar, and that will be announced on our website and social media pages in the coming weeks. And that will also be on a subject regarding immunology, rheumatology, or infectious disease, or patient care. We also just briefly want to mention to save the date for AAIDA's 3rd annual Take the Mask Off Immune Disorders educational fundraiser on May 2nd, 2020. And the keynote speaker will be Dr. Michael Volz of Denver, Colorado, and who is the past president of the Colorado Medical Society. So thank you so much for joining us. This is Lauren Dunlap and Dr. Maeve O'Connor for Advocacy and Awareness for Immune Disorders Association. And we hope you have a great and healthy night. Thank you so much.
Thank you,
Lauren. Thank you, everybody.